subjects. All right, hold on, I got a recording notification. 1 second. Okay, good. So a little bit about background. I'm happy to talk about this topic. It's a very complex area of discussion, of knowledge. I think it's important for all of us to be familiar with this. If you're in any way capacity are going to be covering the hospital service, you will be involved in these situations. Unless you're an outpatient multiple sclerosis specialist, you may not be dealing with this routinely, but this is still something that I think most neurologists really should be comfortable with, especially at your level as you're becoming residents, maybe transitioning to fellowship. You should kind of hear about these things, maybe start thinking about them, start practicing them, and start getting comfortable. I wasn't super comfortable at the end of my residency to just do a brain death exam or know all of the pitfalls and know all of the controversies. It's not, when you're covering a residency, when you're a resident, you're not always on inpatient service. A lot of the times let's say you're covering stroke, other areas of neurology, where you're not going to be kind of having exposure to these cases. Even as a fellow, I did my neurocritical care fellowship. I didn't have dozens and dozens of brain death cases. It really is where at Maimonides, I do maybe 20 to 30 per year of brain death. And I think that's kind of an unusual situation to have one provider do this many. But it sort of forced me into this kind of, clinical comfort where you just kind of, I've seen all sorts of possible cases, all sorts of difficult family situations. And I at this point, years into it, I think I'm beginning to be comfortable, but I just want you guys to also be having some exposure to this, because even the other attendings, right, they don't deal with this. It can be tough, when you do 1 or 2 per year. That's why I just want to talk about this. I'm glad that this is something that, we're going to be discussing, and I'm here for these questions, because this is something that, again, I deal with almost on a routine basis, I would have to say. So, we're going to start with what is death, right? I think that that's really important to start with the definition of death. And by the way, I'm going to be asking questions here, and I want you guys to participate. I'm not looking for right answers. I'm just looking for anything that we can work with, right? That's my teaching style. I don't expect you guys to know this, but I want to have a sort of a discussion on some of these points. So completely okay if you don't know, but you can just give me your best case. This is not a judgmental area here. So what is death? I think that question was fairly straightforward 80 years ago, whatever the case is. It was circulatory respiratory arrest. Basically you stop breathing, your heart stops beating, and that's death. And that's been the definition since the dawn of time, right? You have, cardiopulmonary arrest, and there wasn't really a whole deviation from that standpoint. I want to show you guys this. This is actually a real representation of a casket, of a burial casket that the wealthy used to get back in the day. And what is this contraption you see? This is a bell that goes above the ground. And if you happen to wake up after you're buried and you don't know what to do, you can ring the bell, and people above the ground will hear that you're actually ringing the bell, that you may be alive in the casket. Okay. I think that this is very interesting. That's why I wanted to include it here. There was such a big fear of dying, of being buried alive. There are actually real case reports, real situations that we can all look back to in history. And, someone was presumed to be dead, maybe even buried, and then it turns out that they were not dead. Maybe they had a faint pulse. Maybe they had ROSC for whatever reason. But they were presumed to be dead, and then it turns out that they were not dead. So these situations can still happen occasionally, and they've happened in history before. And, people were so scared of being buried alive or waking up inside, inside a casket that, the wealthy literally had these contraptions as part of their, burial devices, that if you happen to wake up, you ring the bell and folks above the ground will know that you're still alive. And this was an expensive thing. So I think it's interesting to sort of kind of look back and reflect on that. So in 1959, in France, Wertheimer and Molleret really described something, a series of cases called coma dépassé, meaning a state beyond coma. And why are we even talking about this, right? What changed? What changed in the last 100 years that we're sort of starting to talk about what death is? What technological advance made this possibility? Even the whole concept of brain death, what changed? Why was there no brain death in 1650, in 1700s, 1800s? Nobody talked about brain death. Why?
There was no there was no mechanical ventilation.
Exactly. That's really it. Back in the day, if you stop breathing, that's it, right? There was no mechanical ventilation to continue to breathe for your lungs, right? That wasn't a possibility. So it was a little bit more clear cut as far as who's alive and who's dead. So with the advent of mechanical ventilation in the 20th century, that's when you started to have all these case reports, right? A state beyond coma. And they described 23 cases. This is 1959, a first series of case reports where people are saying that this is maybe a state beyond coma. 23 cases in which they are well described to have a loss of consciousness, brainstem reflexes, loss of spontaneous respiration, but they had maintained circulation and they had absent EEG activity. And in fact, they described the condition in coma dépassé, again, super interesting, a state beyond coma. And they described a clinical situation that they believed, from which they believed recovery was not possible. So that's the first sort of a case report series where you're starting to see this. 1968, the ad hoc committee of the Harvard Medical School, right? This is what's known as the Harvard criteria. So, a bunch of smart folks got together and sort of this came up with some way of formulating, how to describe somebody who is maybe in this situation, who's maybe brain dead. And these were part of the initial Harvard criteria. So unreceptivity and unresponsiveness, no movements or breathing, no reflexes, a flat EEG, all repeated at least 24 hours apart. And they wanted to have no exclusion criteria, especially no hypothermia, which they described as 32.2, and no CNS depressants. So you're looking at the base, at sort of the blueprint for one of the first brain death criteria here. And obviously that's been evolving, and we'll go into that. So the committee deliberations focused on whole brain formulations to define brain death. And it really serves again as the foundation of brain death, of the concept of brain death in the US. And really all subsequent work is based on that. That's the fundamental concept here. Then in 1981, you had the President's Commission of basically described, kind of codified the definition of brain death. And the brain death occurs when you have cessation of brain function. Actually, you know what? I should have asked you guys for a definition. I usually start off with that. It's surprising, maybe not even surprising, but it's interesting how many people in the medical field, even in the neurology field, right? I would ask medical students and residents, can you give me a definition of what it means to be brain dead? Very few people are able to kind of give me a definition. And it just talks about how much education we still have when it comes to that people are still not comfortable talking about these things. That you can have a doctor that still can't even tell you what brain death means. I think that's fascinating. We're always talking about, well, the one I hear often is, well, there's no brainstem reflexes. That's true, but that's a criteria for brain death. It doesn't define what brain death is. right? A brain dead patient should have no brainstem reflexes. But what does it mean to be brain dead? Really, what does it mean?
It's irreversible loss of the cortical and brainstem function that's irreversible without confounding causes.
Great. Yes. So that's good. So, but perfect. So let's work with that. So the two key terms are complete and irreversible cessation of brain function. So function is the key, right? Function is the key that a lot of people struggle to come up with that word. They say brain activity. What does it mean? What does it mean, brain activity? How do I assess brain activity at the bedside, right? What happens if you look under the microscope and you see some sort of electron microscope, the whole brain is dead, but you have several neurons firing away? That's a possibility. It may be, it's very, very possible that that happens, right? So if I see one neuron here firing away, one neuron here firing away, does that mean that there's still brain activity? Is the patient not brain dead? It's a tough thing to go over, right? That word function escapes many people. So that's completely correct. So we're looking at cessation of function. So what the brain is supposed to be doing, it's no longer doing. That function is gone, whether or not there's one neuron left out of the whole brain, right? The function of the brain, what it's supposed to be doing, is gone, and it's irreversible. It will never come back. Okay, that's also an important concept. Good. And I actually recently heard this, and I think it's interesting to maybe point out. Irreversible and permanent, right? Those things are actually different. Can anybody tell me the difference between irreversible and permanent? That's a tough one. Is there a difference between irreversible and permanent? And there is a difference. Those are not synonymous words. I heard a brain death lecture, actually, one of my mentors, and I didn't remember hearing this before. I'm like, oh yeah, there is a difference. So let me give you an example. A heart stops, right? You're in cardiac arrest. That may be a permanent situation, but it may be reversible initially, right? You can get ROSC, and at some point it becomes irreversible. So not everything that's permanent is always irreversible. Does that make sense to you guys? I want to hear that. Yes, no?
Yes, it does.
Okay. So something can be permanent, but it could still be reversible. And then at some point, it may be both permanent and irreversible. Here's another, yeah. Yeah, so those are just important concepts to sort of note. So by the definition, so again, the definition is complete and irreversible cessation of all brain function. And those are important key areas. We'll talk about controversy. For example, in United Kingdom, they only go by brainstem. There's something called brainstem death there. They don't really talk about the cortex. As long as you don't have any brainstem function, then you're brain dead. Now, you may talk about when does that happen, right? I don't know if I've encountered clinical situations where you have no brainstem function, but the cortex is still preserved. That's an interesting situation. I think that would be quite rare, but it's interesting that in their definitions, they're not looking at the whole cortex. You specifically, Dima, said the cortex and the brainstem, and that is more of the American definition of the entire brain, right? That's what we say here. And that's important. But in United Kingdom, you can be declared brain dead if you have no brainstem function, regardless of the cortex. Okay. So here, for our definition, cessation of brain function is recognized after you have both cerebral functions and brainstem functions. Again, that's the United States definition. Most of the world kind of goes by this definition, but there are some exceptions, United Kingdom being one of them, where they focus more on brainstem death. And irreversibility. So those are the two things: loss of all function, and it's irreversible. Okay, those are really, really important things. And yes, you have the cause of coma, and we'll go over all of that. I guess we're going to talk a little bit about controversy here. Or maybe we should save a little bit of that. No, let's talk about it now. So, how do we assess brain function? Someone needs to tell me, how do we assess brain function? It's not a tricky question, right? We're determining if someone's brain dead. We get called to do, to assess someone for brain death. How do we assess brain function? You guys are neurologists. Come on, this is not a hard one. I want to hear something.
Neurologic, I don't want to be the only one to answer it, but neurologic exam, we can ask.
Good, that's maybe enough. Neurologic exam,
Yeah.
right? So you're looking at brain function by assessing your exam, right? That's like that's the fundamentals, right? You're at the bedside, you're at the bedside, you're checking their brainstem reflexes, you're checking their mental status, you're checking their motor responses. Your neurologic exam is a way for you to determine brain function. Either it functions or it doesn't based on your exam, right? So exam is a huge part of that. It's not a tricky thing. I guess the reason why I asked it is, if you look at the definition of the formal definition of brain death, we'll go back here. Cessation of brain function, including all cerebral functions and all brainstem functions. Am I assessing all of the brain functions with my exam? Let's be open here. Am I assessing all brain functions with just my exam alone?
No.
The answer is a resounding no. That's correct. For example, what about thermal regulation, right? Is the brain able to control body's temperature? I'm not assessing that. There's so many other functions. An exam is just one big part of your brain function. There are other parts of the brain whose function you're actually not assessing with the exam. You cannot. You really cannot. And that includes many, many things. So if you look at the definition alone, that kind of is a legal discrepancy between what the definition is and what we're assessing. We are not assessing all of brain functions, including the whole brain, the whole cortex, and the whole brainstem. We're assessing some major functions, not all of it. And I'll give you a clear example, right? Somebody we declared brain dead recently was able to maintain their temperature. Isn't that a brain function? Thermal regulation? We're not assessing for it in an isolated way. Now, I do see majority of my brain dead patients have no capacity to do thermal regulation. For example, many of them get hypothermic. You start to see their temperature drop, right? 36, 35, 34. That shows you clearly they have no thermal regulation. But that's not part of our evaluation for brain death. So, and that's just one thing. How about neuroendocrine function, healing? There's really case reports of patients undergoing menstrual cycles, right? Women undergoing menstrual cycles while they're brain dead. That has to have some component of cerebral regulation, right? That has to be, because you're talking about LH, FSH, all these other things. So it's an important thing to point out that the definition as it's written by the letter of the law and what we're doing clinically at the bedside is not really meeting that full definition. We're not assessing all the functions of the whole brain. And that's part of why, I guess we'll get to that later, that they are revising the the Unified Death Determination Act, the UDDA, to kind of have a definition that's more pragmatic. There it is. And in 1981, it's the UDDA, Uniform Determination of Death Act, and that act, the President's Commission basically took on the statute, and this statute has been accepted by most state legislatures. So most of the states kind of go by that definition that we just talked about. And in accordance with the UDDA, the guidelines for brain death are determined and developed at an institutional level. Okay, at an institutional level. And I want to talk about the variability that we have. You guys may be familiar with this. I did my training in Pennsylvania. Even in one hospital in Pennsylvania, we needed to have 2 physicians 6 hours apart. And here it's 1 physician without just 1 exam, and maybe it's 2 if you're an organ donor. That's exactly the policy we have in New York and in Maimonides. It's 1 physician, unless the patient's an organ donor, then it's 2 physicians, and it can be a concurrent exam. There's no need to wait 6 or whatever hours. So think of how much variability there exists just just from state to state. from hospital to hospital. That's a lot of variability. In some states, in some places and hospitals, it has to be a neurologist, a neurosurgeon, a critical care physician. In some hospitals, it can be an NP or a PA in conjunction with maybe a physician doing it. So there's a lot of variability, right? That maybe we should have things a bit more standardized. A little bit more about sort of the injury relating to brain death. Obviously when your ICP is higher than MAP, that's not compatible with life. That means there's no perfusion going to the brain. You have this new initial injury, you have, some sort of a cerebral injury that leads to swelling in the brain. That swelling leads to increased intracranial pressure, and the increased intracranial pressure leads to decreased blood flow to the brain, and that leads to more neuronal injury. And this may be a positive feedback loop until all of the brain is dead. A classic case where you may see something like that is cardiac arrest. Most cardiac arrest patients are not brain dead on admission. Most patients with severe anoxic brain injury become brain dead on day 2, 3, 4 of their hospitalization. So they come with anoxic brain injury, they start to swell, they start to develop cerebral edema that leads to increased intracranial pressure, less blood flow, and then more neuronal injury. And until this process just burns the brain out and there's no viable brain tissue left. Here, so this is, I'll talk about this a bit. I think that this is a very important part of brain death determination. I always want family in the room if possible. I want them involved in the process if possible. If they choose to be there, there's no one forcing them. They don't have to be there, but I always give them the option. The reason I do 20 to 30 brain death exams per year, and you don't really hear a whole lot of controversies, is because I do due diligence. I really want to make sure the family understands what we're doing, why we're doing it, and what the ramifications are. I will never do a brain death exam if the family is not on board. If they don't understand that today we may decide that your loved one's not alive, today is the day they may have a time of death, they may have a death certificate, and the family will need to make funeral arrangements. Those are the 3 things I tell the family. We suspect that your loved one may not be with us, and we'd like to really do a whole battery of tests to see if they're still with us. And we may find out that they're not, in which case they'll have a time of death, they'll have a death certificate, and you guys will need to make funeral arrangements. That's exactly what I say. You do not want to do a brain death exam, and then the family now just understands what happened. And you have a dead patient on the ventilator, and the family's preventing you from disconnecting the vent, right? What are you going to do in that situation? I don't put myself into that situation. It's just, you shouldn't. Legally, what are you going to do really if that happens to you? You can call security and escort the family out and throw them out, and you can actually disconnect the patient legally and send them to the morgue. You have all the legal rights to do that. Do you really want to do that to a family that's grieving? Ideally, you don't want to go in that route. And I have good literature to support that. They've done studies in critical care medicine where family presence during a brain death exam added a lot of closure, a lot more understanding of what it means to be brain dead, a lot more transparency and trust. So I think it's a vital part. Whenever I do an apnea exam or brain death exam, I think that it's really, really important for families that choose to be there, that they're there. Versus me just doing some tests and then I'm calling the family, oh, by the way, your loved one's not alive, we just did some tests. And again, the literature shows that they have a better closure, a better sense of understanding, and they've done randomized trials where they excluded family and they included family. And yes, the families that were included, that were present initially, may have a little bit more of psychological distress initially. 3 months later, they're all much more understanding, they have a much better sense of closure. So again, I think that even the literature supports that families should be involved in this process. These are our prerequisites. This is our formal brain death checklist at Memali's. Sarcoma, irreversible, and cause is known. You want to always have a known cause, as I always do. You don't want to have somebody off the street You have no idea why they're in a coma and you're just doing a brain death exam. You want neuroimaging that explains the coma. And you know what? When I have a cardiac arrest patient, they often have a normal CAT scan on arrival in the ED because it hasn't been enough time to see the anoxia. And if they have a normal CAT scan or close to normal CAT scan, and then on day 2, 3, you suspect that they progressed to brain death, I want another CAT scan that shows me devastating neurologic injury, right? You don't want to have a CAT scan read by radiologist, no acute intracranial pathology, and then the next day neurologist says brain dead, right? That's not a good look. You want to have a chart that sort of, speaks to the story of what's going on with this patient, and you want to have neuroimaging that's compatible with that as well. You want to have absent CNS depressant effects. I often get asked about this, what happens if the patient got a dose of Ativan now? It's a real question. What do you guys think? Somebody got Ativan 4 milligrams. Maybe during intubation, they got Versed. And now I suspect they're brain dead. What is that? What should I be doing? No, there's no specific right answer, but
Yeah, probably will repeat the exam shortly. Like after some time, I will go back and repeat the exam.
Great. Okay, so let's say the patient, this is all hypothetical. So let's say the patient came in yesterday, got intubated, and they gave the patient 5 or 10 milligrams of Versed for the intubation or shortly after or before the intubation. This was yesterday. I'm coming in today, and I think clinically I'm suspecting the patient's brain dead. And it's in their chart that they got 5 or 10 milligrams of Versed. When do you think it would be reasonable to come back?
So if I don't have an explanation for like the prolonged effect of Ativan, like if the patient has normal liver functions and there's no other supporting clinical data and imaging data that said that the patient's probably brain dead, yeah, I think I will just come back and do it.
I'll just add to that. So let's say you have a patient with intracerebral hemorrhage, large herniation, and around the time of intubation in the ED, before or right after, they got 4 milligrams of Ativan, and their CAT scan is consistent with a severe intracerebral hemorrhage. Again, yesterday they got Ativan in the morning, and today you're seeing the patient and you suspect that now their herniation has progressed and they're brain dead. What do you do about the Ativan that they gave yesterday? If anything, it's an open discussion.
I think if it's just yesterday, I will just go proceed with brain death examination. Yeah, it's yesterday.
Okay, fair. So let's say it's been yesterday, so you suspect that it's not long. I think I would agree with that. The question that I'm trying to answer is this a confounder for me based on what I'm seeing, right? Is 2 milligrams or 4 milligrams of Ativan yesterday morning, is it really confounding my exam? Do I have that suspicion? And I often may not. I think I agree with you in this case. I don't know if I would wait a whole lot longer. But I often get asked, well, let's do a UA screen, right? Let's do a UTOX. How long is the UTOX going to be positive for in this kind of a patient?
It may still be positive in if the patient got the Ativan yesterday and I just repeated that next morning, I think it can still be positive for benzos. Yeah, it will.
Yeah. It definitely will. It's 3 to 5 days sometimes the benzos may stay, just as far as the UTOX, right, of benzo derivatives, easily for 3 days. So does it mean because the patient got a little bit of benzos, or even let's go with fentanyl, right? During intubation, they got a little bit of opiates. They may still have a positive opiate screen for a few days. And what does that mean, right? I guess the question to me is it still a confounder? Do I think it's clinically confounding with what I'm seeing on imaging and on the exam? And I would agree with you that maybe 2, 3, 4 milligrams of Ativan yesterday morning is not enough for me to consider it a confounder. So no, I personally don't want a UTOX that's just going to show me not a level, it's just going to say positive or negative, right? So now I got a UTOX that's going to show me positive for either opiates or benzos, and I'm doing my brain death exam. That doesn't really look good in the chart also, right? Because it really is just a positive or negative. It's just black or white, yes or no. Good, so I think that we can agree there. How about, let's change the situation a little bit more. The patient was in status epilepticus after intracerebral hemorrhage, and the patient was on Keppra, valproic acid, and also on midazolam drip for a few days, 10 milligrams an hour, which was discontinued yesterday. And now you think the patient has either rebled or has progressed with their hemorrhage or cerebral edema and brain dead. How long would you wait for?
I will still need to check that the patient is not in status anymore. Like I will definitely need
So
to do
let's
that.
pause that. I like that. So I guess what I would say is, yeah, okay. So if you're suspecting brain death, by definition, you shouldn't be seizing, right? There should be no function of the brain. That includes no seizures. If you're seizing, you're definitely not brain dead. If there's enough brain tissue that you're actually it's seizing, then that's a different pathway. And yeah, I agree with you. So let's say, you know, on the EEG, you're not seeing any seizures. You know, yeah, that's been ruled out. How long would you wait? And the patient's been on Versed 10 milligrams an hour for 2 or 3 days.
And now he's off Versed, right?
Off of everything since yesterday morning, and now it's, you know, yesterday afternoon, whatever. At noon yesterday, you know, everything was stopped. The patient has had, you know, loss of all brainstem reflexes. You did an EEG just to rule out any more seizures that could be kind of confounding this, and it was just flat, no electrographic seizures, and you know you really have a suspicion that he may be brain dead. And you know now it's morning, and yesterday around noon everything was stopped, and the exam.
Yeah. So yeah. So in such a case, I'll proceed with my examination. Yeah, brain death exam. Yep.
Interesting. Okay, so okay, I like that. But then when do we? How do you know it's not a confounder now? Not because here it becomes a little bit tougher, right? You're talking about 10 milligrams of Versed an hour for 3 days. That's, you know, 240 milligrams of Versed per day for 3 days. How do we know that it's not a confounder here?
I think some people recommend.
I'm gonna quickly interrupt. How can you? What if somebody, a hungry lawyer looking through the chart, is going to say, hey, you've accumulated 240 milligrams of Versed per day over the last 3 days. That's almost a gram of Versed or whatever, not whatever, a whole lot of Versed. And maybe that overdose or whatever high benzo activity, maybe that's now suppressing all your brain function, that you really, really have accumulated all this Versed, and it's either causing this situation or it's a major confounder. What would you say to that?
I think the rest of the criteria still point to, you know, the fact that the patient is like brain dead. So maybe
well, you have a suspicion that the patient's dead.
Yeah,
right? Clinical suspicion.
I don't know. This is a tough one.
It is. That's why. Yeah, it's interesting. What do you guys think? What, you know, we could do the same thing with a fentanyl drip or Versed drip. At which point do you feel comfortable? And maybe you're even scientifically justified to say this is not a confounder.
I say the medication should be limited like 5 half-life of the medication.
Good, excellent. So excellent. So it's 5 half-lives. That's an actual real. So 5 half-lives. That's the answer, right? So what is the half-life of, you know, of let's say Versed? Let's say it's 4 to 6 hours for half-life, right? So what is 5 half-lives? So you want to calculate. So the right answer is if you have significant sedative drugs that you're using, both either not propofol, either Versed or fentanyl, you really want to wait 5 half-lives. Okay, that's the real answer that's more scientifically justified, because after 5 half-lives, you go by half, and at the end of the 5 half-lives, you should have negligible amounts left. It should be a minimal, if any, confounder at all. So the answer is when you use barbiturates, when you use benzos at real, you know, at meaningful doses, opiates, 5 half-lives is what you wait for. So in something like Versed, by the way, which accumulates in your fatty tissues with the longer use, especially over 2 days, the half-life can be even prolonged. It can be 4 to 8 hours for 1 half-life. So let's say, you know, 6 times 5, that's 30 hours. So if you go by just 5 half-lives in this patient, you have to wait a minimum of 30 hours. That's a minimum. What else is affecting your half-lives here? It's not just the time, right? You have to be mindful of these things. People get burned with this kind of stuff.
Kidney and liver function.
Excellent. Your kidney and renal function, right? What's 5 half-lives for me, for you, it may not be the same in a patient with cirrhosis or with liver failure as far as benzos, right? Their 1 half-life can be 18 hours, 15 hours, 12 hours for 1 half-life, especially with prolonged benzo use, right? So you have to be mindful of that. What else can affect your half-life?
BMI, maybe.
Did you say BMI?
Yes, I did.
BMI, yeah. I mean, I'm sure it does to some extent. Yeah. I mean, you know, like 10 milligrams of Versed for a 300-pound patient is not the same as 10 milligrams for a 50-pound patient. I mean, there's some truth to that, no question. What else? Another big one in our line of work. Temperature.
Interactions, like drug interactions.
Yeah. So drug interactions for sure. You should be kind of thinking about all those things. Absolutely. I just want you also to think about temperature. Hypothermia increases your half-life. So you have a patient with, let's say, liver or renal failure, and they're hypothermic after cardiac arrest to 35.5. Maybe it's intentional hypothermia where they've been cooled, targeted temperature management, or just for whatever reason they are hypothermic themselves, especially if you're talking about brain dead, right? We just discussed that a lot of these patients lose thermal regulation and they may be hypothermic. So if you have a patient with a temperature of 35 with renal and liver failure, and you've been given Versed or fentanyl, for an average patient, the half-life is 4 hours. For this patient, it literally may be 18 hours for 1 half-life. You have to be mindful of that, right? I want you to think about these things, that think about half-lives in terms of individual patients, you know, not just a straight number. And it may be a straight number in an otherwise, you know, a patient that is normothermic and has normal renal and liver function, but you don't want to get burned in these other situations where somebody has liver failure and their temperature is 34, and you'll say, well, we waited 24 hours, that's 5 half-lives or something.
Dr. Levin?
Yes.
Can you use EEG to guide you?
To guide what? I love that. Tell me, to guide what specifically?
Yeah, to guide you, because we are considering the benzos, right? And
Yeah, so let me ask you
sort of
this.
toxicity.
So how is an EEG going to guide you whether or not benzos are still in your system? If anything, go ahead.
Yeah, but since we're talking about the benzo to the level that can cause the severe coma to the, or like branded picture, it means the EEG has to be telling you.
But I guess
like
how would you say that all the benzos in your system, maybe they've built up, and especially with
right, but currently the patient, if you're suspecting currently the patient is on the benzotoxicity state, it means EEG has to tell you, right?
How? Tell me, what are you
Burst suppression.
Yeah, so I guess what I would say is, it's a great question you're asking. What I would say is, when you have a severe brain injury and loss and some injury, let's say you have uncal herniation, right, and really a blown pupil or already minimal brainstem reflexes. Let's say a patient, all they have left is just triggering the vent. So the bottom part of medullary respiratory center is still intact, and you've lost all of your brain function except for that breathing. You're still triggering the vent, right? That's the last part to go. Maybe in a patient like this who's lost 98% of their brain function, you give them so much benzos on top, you're going to have a flat EEG. That can be a severe confounder to an already injured brain. So I don't know if the EEG is going to really, I guess my question is, can EEG tell you whether or not the benzos or fentanyl or anything is confounding your exam? Unless you have some activity on the EEG, I think just getting a flat EEG doesn't tell you if it's flat because the patient's brain dead, or if it's flat because they lost 98% of their function, and then you're adding a whole bunch of sedatives to that. It could just be flat from that point also, right? Does that make sense?
Yep, thanks.
And you often see that. What happens when you overdo propofol versus fentanyl? Burst suppression. And I have seen patients where you give them such a high amount of sedatives, the bursts are getting more infrequent to the point where it's becoming flat. right? So in those patients, you stop the sedation and then easily you can come back, you get some cerebral waves. But what happens again when you've lost 98% of your brain function and maybe you overdid it with the sedatives, right? You don't know what's what at that point. And the question we're trying to answer are drugs a confounder here? So EEG is not super helpful to answer that specific question. It may just be flat because you're really brain dead. It may be flat because you're almost quote unquote brain dead and you have a lot of unnecessary sedatives on board still. It really doesn't answer the question of, are drugs still affecting you or not? At least not reliably. You cannot just go based on EEG, because even if it's flat, you could make the case it's flat because of the benzos, in addition to your severe neurologic injury. So the right answer is, if you have a level of something, like you can measure barbiturates, right? You can measure that, you can go by those levels. It's hard to go by benzo levels. It's hard to go by opiate levels. I'm not aware of those being used routinely in these situations. So the right answer is you wait 5 half-lives. Okay, if they're on Versed, you look up the specific half-life of Versed. If they're on fentanyl, whatever they're on, you look at the normal half-life and you anticipate and you look at your patient. Do they have normal end organ function, normal liver, renal function? Then you can go by that normal half-life. If they're hypothermic, that increases your half-life. So in a patient with liver failure, who has been receiving substantial, again, I'm not worried about 4 milligrams of Versed 24 hours later, because even 24 hours later, whatever Versat's in your system from a small dose is not going to make a meaningful impact. But when you're on drips or high doses, you should start to take that into consideration and really look at the end organ function, liver renal function, and also look at your temperature. And there are situations where I may have to wait 48 hours easily, sometimes 3 days, based on the patient's specific situation. So that's that. No evidence of residual paralysis. You want absence of severe acid-base, electrolyte, or endocrine abnormality. Again, what is severe, right? It's not a specific definition that you guys are getting here. I guess what I would say is I look at the patient and the clinical situation. I'm not going to do a brain death exam with a pH of 6.9. I'm not going to do a brain death exam with potassium of 8.1. I'm not going to do a brain death exam. Well, let's talk about endocrine situations. What kind of endocrine situations can confound your brain death exam? Two specific ones I'm thinking about.
Thyroid, like hyperthyroidism.
Excellent. And the worst manifestation of that is called what?
Mixed edema coma.
Perfect. Exactly. Mixed edema coma. Because again, if you have a severe brain injury and you have severe hypothyroidism, you can lose reflexes that may or may not come back. I once had a case where somebody documented mixed edema coma and then they called me for a brain death. I don't want to be the next guy in the chart documenting brain death when the team is documenting mixed edema coma, right? You want endocrinology on board to clear this kind of patient. Perfect. So mixed edema coma is one. That's a red flag. What else?
And second, hypo or hyperglycemia.
Yes. So you don't want to assess for brain death if somebody's blood glucose is 30. Sure. What else? So Addison's disease, severe hypocortisol syndrome. Basically you want your adrenal function to be preserved, and if they have severe Addison's disease, it's something to keep an eye on. A little bit of a flag there. We all know about normothermia. There's been many case reports when you have people drowning in ice cold water, and then they look like they're brain dead, and you rewarm them, and then regain brain function. Systolic blood pressure above 100. You don't want to assess brain function when their blood pressure is 50/30, right? That's not the optimal situation to assess brain function. You want the perfusion to at least the hemodynamics to be to allow you for adequate testing, and obviously no spontaneous respirations. So all of these are just the prerequisites. Okay, it's just for me to even start formal brain death testing. So coma, irreversible, and I know the cause. Imaging consistent with what I'm suspecting. No sedatives on board that are meaningful confounders. No paralysis. no severe acid-base electrolyte or endocrine abnormality. The temperature is normal, and by normal, we mean more than 36 degrees. Systolics above 100, or MAP above 65, and no spontaneous respirations. If you meet all of these, I can start doing a formal brain death exam. Make sense? Questions up to this point so far? Okay, so I want you guys to see this. I remember not so long ago this case report. Okay, this is published in Critical Care Medicine, guys, not a small journal. You may have heard of it. Reversible brain death after cardiopulmonary arrest and induced hypothermia, 2011, right? So this is an oxymoron. There is no reversible brain death. By definition, brain death, as we had just discussed, is irreversible. That's the definition of brain death, right? And there was a large outcry from the neurology community about this case. And what do you think happened here? Guess what? The guy was on a lot of, had a cardiac arrest, underwent hypothermia protocol, had a lot of sedatives on board. They waited, quote unquote, 5 half-lives without taking into consideration the temperature and the half-life in this patient with liver failure. Okay. And then guess what? You rewarmed him, well, he was rewarmed initially, but you waited a little bit longer. All of the sedatives wore off, and then this became the patient, lo and behold, was not dead after all. Okay, and what happens? This was published in 2011 June, 2011 September, same journal. There is no reversible brain death. I think that's kind of an interesting thing to sort of highlight here. You can get burned. Again, I want to teach you here. It's a sort of, it's not cookie cutter, 5 half-lives and that's it. Most, to my knowledge, every time brain death has been performed carefully, diligently, it's never been reversible, and meaning that you've really took away all the confounders when you followed the protocol to a T. And they did follow it here, but they didn't allow for, for an average guy, though that was enough 5 half-lives. For this patient, they didn't take into account his end organ damage and his temperature. And that's why they decided to publish this case report, but then they had to take it back because, it's not that the brain death is reversible. It's the criteria which they used to determine brain death were probably not accurate. They didn't allow for appropriate waiting period in this particular case. Okay, so our exam, this is how we assess brain function, right? It's our exam. That's really what we're relying on. So pupils, corneals, oculocephalic reflex, which is Dole's eyes, oculovestibular, which is cold calorics, no facial movement to noxious stimuli at supraorbital nerve and TMJ joint. Why do they want this? They want something above the neck, right? You can have a C-spine injury. They want something above the neck to sort of, kind of rule that out. Gag, cough, and absence of motor responses to noxious stimuli in all 4 limbs. And then this is a key thing here. Spinally mediated reflexes are permissible. Keep this in mind, guys. We recently, maybe some of you guys were on the case. We recently had a patient with very complex spinal reflexes still intact, although the patient was brain dead. 20%, guys, 1 out of 5 patients who are brain dead will still have spinally mediated reflexes. So that's 1 out of 5. These include, most of the common ones are going to be in the lower extremities. You can have Babinski, you can have triple flexion. Triple flexion is probably the most common one that I see. It's a brief, again, flexion in your hip, knee, and ankle, and then it's not sustained, and then subsequent relaxation. So you should be prepared for that. And, I often see them, and you just want to prepare the family for that. If you do see spinal reflexes, and explain to them that these are not coming from the brain, they're just coming from the spinal cord, and that's a big distinction. Apnea testing, I'm not going to go into a whole big kind of detail here, but the point of apnea test, what is our main respiratory driver in average folks? What's the main respiratory driver in us right now? What causes us to take another breath? What is it?
Carbon dioxide.
Carbon dioxide, that's correct. It's not oxygen, it's carbon dioxide, right? So that's why sometimes swimmers, right, they hyperventilate, they get their PCO2 down, and then they take a dive, and they feel, you know, they have they lose the air hunger for a while because their PCO2 is so low that now it has to build up before they start to want to take another breath. But it tells you nothing about your oxygen levels. Your oxygen can be very, very low, and you could still not feel the urge to take a breath. That's why when you overdo it, it can be dangerous. You can hyperventilate, dive, and, you know, pass out underwater because your oxygen is so low, but you still don't have a need to breathe. So again, it's the carbon dioxide in an average person that prompts you to take a breath. In severe COPD, that changes, and you actually get hypoxemia as maybe a driver, but it's a late driver, and it's usually not effective in average healthy folks. So the point of apnea testing is you pre-oxygenate the patient, you give them a very, very high amount of oxygen in the blood, you put them on 100%, and you want them to have a very high oxygen level throughout the whole test, and you want to start with a normal carbon dioxide. You have a very high oxygen level, a normal carbon dioxide, you take them off the ventilator and you observe their chest for 10 minutes, and the whole time your oxygen should be slowly coming down, you know, and really in a normal patient, they should still be setting 100 or 99 throughout the whole time. Again, the oxygen is going to go from very high to just high or normal, but the PCO2, carbon dioxide, should go from normal to very high. And if you can document that it went from normal to very, very high, and you still haven't observed any respiratory effort, that's consistent with brain death, that, you know, that medullary respiratory center is not functional, right? That's a test for function. You're checking for medullary function, right, with the apnea test. All right.
Dr. Levin,
Yes.
can you achieve these oxygen levels even in patients with severe lung injury and subsequent brain death?
Yep. So many of my patients that I see do not qualify for apnea tests. What are the most common reasons? ARDS, right? So I need to be able to pre-oxygenate you. If I'm coming into the room thinking about brain death, if I see anything on the ventilator over 40%, already I'm like probably not going to be a candidate. You have to be able to tolerate being completely off the vent for 10 minutes without your oxygen levels falling. Okay, so when I see pulmonary edema, severe pneumonia, ARDS, right? When your oxygen requirements are high, FiO2 is high, PEEP is high, I don't even bother, right? Because I'm just gonna have to terminate the apnea test. They'll start to desat. So many of my patients, that's correct, are just not suitable candidates for apnea testing. So it's a really, really important point. Does that answer your question?
Yeah, but they can still be brain dead.
Correct.
Right?
We'll go into that next part. So that's very, very important. Thanks for asking that. So the two things minimum required to determine somebody brain dead is a full neurologic exam and an apnea test. So if I have a neurologic exam and an apnea test, I'm done. That's it. I can confirm. I can declare somebody brain dead. If I'm unable to do an apnea test, let's say just the situation I described, somebody's on 60% FiO2. Their ABG is not great, they're desatting. I'm not going to be able to do an apnea test. So in that situation, or I can't do a full neurologic exam, either or, right? In which situation I may not be able to do a full neurologic exam. Let me give you an example. You have a C-spine injury, right? Severe C-spine injury. This is a level 1 trauma center. I don't know if your exam below the neck is reliable. I don't know if it's valid if you have a C-spine injury. Even the apnea test may not make sense, right? What if your diaphragm is affected? How do I know it's not a confounder here? What if it's a motorcycle vehicle accident? You're missing an eyeball, right? You're missing one arm. You're missing something else that's corneal abrasion. I'll do the exam that I can. I don't know if I'm comfortable declaring somebody with one eye and the other eye is missing. I can't even assess it. That's a big limitation, right? So either if I can't have a full neurologic exam or I can't do an apnea test, then you get what's called ancillary testing to help confirm brain death. So the minimum is neurologic exam and an apnea test. And if I can do that, I'm done. If I cannot do a full neurologic exam or I cannot do an apnea test, then I get an ancillary testing, additional testing to confirm. So what is some of that testing?
Dr. Levin, I'm sorry to interrupt you. I just have a question about the apnea test. How much the blood pressure should be, and can we keep the patients on pressors during that?
Absolutely, you can keep them on pressors for both the exam and the apnea test. It doesn't matter how many pressors they're on, 3 pressors at max doses. If their blood pressure is above 100, it's a valid exam and it's a valid apnea test. So normally I prefer systolics above 100. I think we may have something here. Do we have anything here about blood pressure? No, I think the previous ones have it here. Yeah. Systolics above 100, and some people say 90, 100. I like it, to be above 100 for both of them. The one thing to note, and I'll just tell you briefly, when you're doing an apnea test, if the patient's on pressors, first of all, if they're maxed out on 3 pressors, I don't know if I would do an apnea test. I'm okay with 1, maybe 2 pressors, 3 pressors maxed out. I don't know if they're stable to actually do a full 10-minute, 12-minute apnea exam. The other thing to note is during an apnea test, it's a good point. I actually thank you for bringing it up, Dima. You may develop severe respiratory acidosis. That's the whole point of it, right? Your PCO2 goes up, your carbon dioxide, let's say, goes from 40 to 75, and your pH, because of this carbon dioxide buildup, will go from 7.3 to 7.1. Let's say that can easily happen. What do we know about pressors in an acidotic environment, in an acidotic patient? They don't work so well.
Yep.
Correct? That's why we always want to correct acidosis. Pressors are not as effective. So what I often find, and you need to be prepared for this, if you're doing an apnea test and the patient's on pressors, during the apnea exam, you may have to go up on the pressors until you reconnect them and you blow up the PCO2 again. So I always have the nurse in the room. I always prepare everybody that we can anticipate some hypotension. And usually you start to see 125, 118, 107, 98. And I say, let's go up on the pressors. You do. And then the moment you again connect into the vent, they blow it off, they go back to their baseline, what they were before the apnea test. But you should be prepared to deal with hypotension, worsening hypotension during the apnea exam. It's very common because
I don't abort the test if the patient develops hypotension. I deal with it and I continue the test 8-10 minutes, right?
Yeah, if you can. Obviously, if it's at any point, if you think the patient cannot handle it, you terminate the test. But if it's sort of what I anticipate and I have room to go up on the pressor, let's say the patient's on half of norepi dose. I max out norepi, I finish my apnea test, and then I go back to their baseline half norepi. That's all. Okay, so this is some ancillary testing that is used in the literature, in the medical centers. All of these you can use. The most common and the most used one is going to be the second one, which is a nuclear blood flow study, also known as cerebral scintigraphy. Okay, and it's a nuclear test that actually where you inject contrast and you want to see is any contrast actually making its way up to the brain. What happens if you're actually brain dead? You have an abrupt cutoff right here at the carotid terminus. That's exactly what happens. And I even thought myself, why does that happen? Like, you can be brain dead. Wouldn't a little bit of blood still kind of get pushed into the brain, or just kind of, just passively go there? The answer is no. It's not that you have dead brain, but all the highways that supply the blood and vasculature are still preserved, right? You don't have normal arteries, arterioles, venules, right? You're talking about arterial connecting to venous, returning the blood back. All of that is dead. You have liquefactive necrosis. None of that's normal. If you are brain dead, you should not be seeing normal arteries and veins in the brain. It's not, again, like there's normal highways, but then everything around it is dead. The whole organ is dead. And you should be seeing that. And this is what it would look like. This is a formal angiogram, but you see this normal kind of cerebral vasculature and anterior circulation. And here you have this abrupt cutoff in the same patient. Okay, and that's what true brain death looks like. Okay, and it's very important to note that. So again, if you're truly brain dead, there should be no blood going to the brain. The other thing I'd like to mention is you have a common carotid that then splits into internal carotid and external carotid. Internal carotid supplies the brain and the eye, right? Ophthalmic artery, and then external carotid supplies the face and ears. So if you're brain dead, all of the blood that's in the common carotid now cannot go to the internal carotid. It doesn't really provide any supply to anywhere. So all of that blood has to go from common carotid to external carotid. So the external carotid is seeing more blood than it's normally sees, than it's used to. Where does this external carotid now go? It goes into the face, it goes into the ears, cartilaginous tissue, and it goes into the nose. And what you have is sometimes called this, the hot nose sign. Okay, so look at this patient where you have a pooling of blood in the nose, in the cheeks, in the ears, and nothing in the brain. Okay, and this hot nose sign is almost pathognomonic for brain death in this nuclear blood flow study. Again, pay attention, nothing in the brain, it's empty here, and look at all of this face tissue that's now more, getting more blood than it's used to, especially this pooling in the nose is classically described in these patients, and we often see this situation. Hot nose sign, I think it's really interesting. I wanted to include it here. It's very visually interesting to see, kind of scary looking when you see it for the first time, and it stays with you. I think it helps you kind of remember this whole discussion. Questions? So let's just recap. My mentor once taught me, I think appropriately, you do the minimum amount of testing needed to be confident that someone's brain dead and not more. You don't want to appease the families. You don't want to start ordering extra tests. It's only going to backfire against you. So you can, the minimum is a full neurologic exam and an apnea test. If you either cannot do a full neurologic exam or you cannot do an apnea test, then you get ancillary studies. The best one being this cerebral nuclear blood flow study that actually shows you, is there any blood going to the brain? And transcranial Dopplers and EEGs are also on the table, but there's other reasons why I can go into that, why they may not be ideal, such as this test. And that's that. So again, if you can do a full physical exam and a full neurologic and an apnea test, you will need ancillary testing. And I would aim for cerebral scintigraphy or a nuclear blood flow study, if at all possible. If not, then the other alternatives may be transcranial Doppler and an EEG, but those are user dependent. There's special specifications. They have to be done in a specific way with a specific trained person. And again, you do the minimum amount of needed. You don't want to order everything just to convince the family, because if the family's not convinced at this point, you ordering another study and then the EEG is read at minute 25 cannot exclude that this wave is of non-cerebral etiology. It's just you do the minimum amount needed to make yourself confident that the patient's brain dead. And when you're confident, you shouldn't order more studies. And again, neurologic exam and an apnea test. If you can't do either one of those fully, then consider a nuclear blood flow study or some other ancillary testing. Questions?
Just a quick question for the caloric test. We should have absence of eye movement whatsoever, right? Is correct?
Correct.
Okay.
You should see nothing at all.
Okay.
Nothing at all. They describe CALS, cold opposite worm, same, and you sometimes use it in textbooks used in coma patients in the emergency department to see if they're faking the coma or not. You should see nothing. You should see no eye movements anyway, because if I'm putting cold water in your ear and I see any eye movements, even if it's freaking vertical, I should see nothing, right? It should have zero impact, because that's telling me there's still some brain function. Me putting cold water here and having any eye movements implies that there's some function, and I should see zero function in a brain dead patient.
Thank you so much.
Anything else you guys want to ask? This is a tough topic, guys. I'm happy to answer.
Dr. Levin.
Yep.
Like, if you have a case like one day we had a case like ALS patient with like 5 or 10 years in vent and only eyes are moving occasionally. So if with this kind of patients, brain death, calling the brain death is going to be very hard, right?
Well, I would ask you, is the patient do you even have suspicion that the patient's brain dead? You're telling me eye movements. What is that? What's going on there?
I mean, at some point the patient may be dead and then eye movements will stop, or
I guess, look, my clinical suspicion is if I see any imaging, right? Also ALS, I don't know why this patient would be brain dead. So I would have to see some brain imaging that makes me think, man, this patient may not survive this. As a matter of fact, it's so bad, maybe they've already lost some brainstem reflexes. And then I go at the bedside, and I see a neurologic exam where you have blown pupils, no corneals, no cough, no gag, you're off sedation, you're not triggering the vent. There's no motor responses, right? And sometimes I see the exam first and then I look at the imaging. So those are the things that make me suspicion. And that's what I always say. I have clinical suspicion that this patient's brain dead, and I'd like to confirm it with formal testing. So, this patient, if I actually see blown pupils, no corneals, no cough, no gag, and a terrible CT, then I would maybe consider formal testing. Otherwise, if I have eye movements, anything else, then really by definition, that means the patient's not dead.
Got it. And how long can you protect the making decision on the patient? For example, you're considering like a longer half-life due to hypothermia, etc. And do you have any time constraints or any push from the insurance companies? And
It's a good question. So I have no time constraints. No, I'm trying to figure out, these are the sickest of the sick patients, right? They're not coming outpatient. You're suspecting someone is so sick that they may be dead at this point. I've never heard an insurance company, say, hey, we need to do brain death testing. I would get sometimes a push from Live on New York, our organ donor, organ procurement organization that, that works with us. And they will say, hey, can we go ahead with the brain death testing? So maybe this patient would be a candidate for organ donation. And all I would have to say is, I'm not there yet. Clinically, the patient doesn't meet criteria, right? If you decided that you have 5 half-lives, for example, the patient's been on massive doses of Versed, and I'm going to say I need 48 or 72 hours or something. The patient's not brain dead, right? They don't get to decide who is. They can prompt you, and you can tell them, hi, because of this large sedatives on board, we need to wait this many hours, this many days. But usually we're talking about some amount of days, not longer than that. The push that you can get is if you declare somebody dead and the family refuses to acknowledge it, who's going to take a dead patient now? Which insurance company is going to pay for a care of a dead patient now, right? Which facility is going to accept a dead patient into their facility now? So you don't want to be in this situation. If I could teach you anything, is just to be careful and always just be mindful of never declaring a patient with a family that has no understanding what you're doing. That you shouldn't have. That's all I want to say. Does that answer your question a bit?
Yep.
And I guess the one more thing is that I think that the whole concept of brain death, to me, in my mind, I don't know if other people would agree, there's 2 main prerogatives, there's 2 main priorities, there's 2 main things why brain death even exists as a concept. Number 1, it's for organ donation. Okay, without brain death, a lot of the folks wouldn't get a second heart, a liver, whatever, and and that's a big deal because people have a new lease on life. So number 1 is organ donation. Okay, that's a big deal why brain death exists. And number 2 is closure for the family. Okay, the family is at the bedside. They want to know, is their loved one still alive? Are they going to make a recovery? And you telling them that this patient is now dead, it gives them a closure. The patient goes to the morgue if they're not an organ donor. They make funeral arrangements and they try to deal with what they have at that point. Versus just continuing to have a dead patient with all of these aggressive artificial measures, and the patient's really not with us. So if I can't help with one of those 2 things, I don't really push so much for brain death. Either the patient may be a potential organ donor, or it may help with the closure of the family. If it's a Hasidic Orthodox family here that we serve this community, right? Let's say you have a part of somebody that's Hasidic, they don't believe in the concept of brain death. As long as the heart is beating, you're still alive, right? So this family is not open to organ donation, and then you're giving them no closure. by declaring somebody brain dead. They don't acknowledge that concept. You're causing more moral distress to this family. I would never declare, and I have not, and that's our hospital policy. If somebody based on religious principles does not believe in the concept of brain death, you do something called reasonable accommodations. So I would tell the family, yeah, your loved one has a catastrophic neurologic injury. I'm not going to declare them brain dead. And I would document in the chart, patient with poor exam, likely imminent mortality, poor prognosis, injury not compatible with survival. And that's it. And 99% of these patients are not going to even make it outside the hospital. They will go into cardiac arrest. It's a tough issue, you know, but I don't pursue brain death in those patients where I'm not giving the family closure and they're not candidates for organ donation. I just document catastrophic injury, poor prognosis, likely imminent mortality. And, you know, what happens is when the brain goes, the heart follows. The rest of the body starts to shut down. You don't make endogenous steroids anymore, right? You're not making cortisone. You're not making thyroid hormones. So it really is a matter of days until they go into circulatory collapse and death.
Did you just ask that question?
It's your, yeah, you can ask.
Hi, Dr. Levin.
Hi.
Hi, so yes, I think it was last week during that brain death examination that we had those odd spinal reflexes. He gave some characteristics to help us know to distinguish between actual spinal reflexes and not. I just wondered if you wanted to share it with the team just in case they encounter it.
Great. Thank you for asking that. You know, I try to balance. I don't want to overload you guys with so much information that it becomes a whole lot. But yes, that's really an important thing. So spinal reflexes, reflex by definition, I look for three things. Reproducible. So if it's a reflex, you should be able to reproduce it, right? Versus something that's movement or anything else. Reproducible, not sustained, and stereotypical. So you can reproduce it. It looks the same every time. A true withdrawal, right? If you're painting me, if I'm painting a patient, their withdrawal, once it's going to look like this, another time like this, something else. It's going to look different every time I'm doing it. A reflex, you'll be able to reproduce. It will look exactly the same every time. For example, this patient had ipsilateral head turn. So I would paint, I would paint him and he would just do this every time, just head turning to ipsilateral. So it's reproducible, it's stereotypical, it looks the same every time, and it's not sustained. A true withdrawal, if I keep painting you, you're going to continue to withdraw until the stimulus goes away. Whereas a reflex, you have a contraction, and despite you continuing to apply the stimulus or the pain, it just goes away, and then they just go back into their normal position. So again, three things that point to reflexes: reproducible, stereotypical, not sustained. Those are consistent with reflexes. And you can write it down because you just, you know, those things are sometimes required commitment to memory. But yeah.
Thank you so much.
Yeah, you know what? Maybe I could show you something real quick before we call it a day. I want to see if I could show you a video of complex spinal reflexes in a patient with brain death. I want to show you a YouTube video here. I think it would be good to see. All right, let's see how I can share this. 1 second. You guys don't see this, right? The YouTube, not yet?
No.
Okay, hold on, let me see. I'll share this with you. Screen sharing. New share, here you go. Here you go. Let's do this. Are you seeing this now? Yes?
Yes.
Okay, so this is a boy in Brazil who's brain dead. And this is, you know, they call it the Lazarus sign. I guess this can be thought of as a variation of this. I want you to see what happens when they move his neck. And this is a brain dead patient, and just movement of the neck, the spinal manipulation is causing these spinal reflexes. I want you to see what they look like. Here.
Yes. Muito bem.
You guys saw that, right? That's really interesting.
Agora abaixa os braços dele.
Again, they bring his arms down and they'll do it again. See, they do supraorbital pressure, nothing.
Agora na articulação temporomandibular.
TMJ pressure, nothing. So this is
Both.
reproducible, stereotypical, and it's
Mostrando
not
que o
sustained.
paciente é um
And again, they're gonna
reflexo
flex
regular
his
do
neck,
músculo
see,
cervical.
nothing, and then again, they're gonna flex his neck and you'll see his arms.
Agora flete a cabeça dele. Fletindo. Isso, muito bem. Mostrando que é na medula.
See, so this is very, again, this may be very distressing to the family, right? You have to be prepared to talk about these things and deal with them. Good, questions? Good, I guess we'll call it a day. It's a tough topic. If you guys have anything you wanna clarify, I'm happy to do that because, you know, these are not easy situations, but I want you to get comfortable at least managing them, declaring them, at least knowing the process, you know, knowing what it entails. Again, it's the neurologic exam and apnea test. If you can't do either or, you proceed with an ancillary study. The one that's most favored is a cerebral blood flow study, nuclear blood flow study. Sounds good?
Thank you, Dr. Levin. This was great.
Excellent. I'm talked out for this afternoon. Thank you. Have a good one. Bye.